Hello? Mkwazi? Ante kwa simu. Tulikimpisha indiani. Mungu akwazi.
Okay, let's start. Let's start our revision today. This revision will be recorded. Okay. Hello, everyone. Good evening for all of you. I'm Ahmed Gad, and I'm truly excited to have you here with us today for this free OPRA exam revision session, proudly presented by PTEC or Pioneers Test Preparation Center. Whether you are just starting your journey or deep into your preparation, you are in the right place. Today is all about boosting your confidence, testing your readiness, and giving you taste of the structured support we offer in PTEC or at PTEC. In this session, we will work together through 60 high-yield MCQs that are carefully selected to reflect the real OPRA exam style and difficulty. These questions cover a wide range of pharmacy topics and are each supported with detailed answers and rationales. So you don't just memorize the right option, but understand why behind it. Our goal is simple: to sharpen your critical thinking, highlight key clinical concepts, and help you avoid common traps in the exam. Before we begin, a few quick instructions to make the session smooth and productive. Firstly, your mic will be muted by default. This helps reduce background noise. If you have a question or comment, feel free to type it in the chat at any time. And if something isn't clear or you want to discuss a specific point in real time, please feel free to unmute yourself and stop me. I'm sorry. We welcome interactions. So you can interact at any time you want. At the end of the session, we will open the floor for general questions and discussion. So save any broader topics for then. Now, if you find this session valuable, and I'm sure you will, then you will love that what we have built in the complete OPRA revision course. It includes 3 full lectures, full revision, including the most recent recalls of the last exam. Each one packed with hundreds of MCQs, exam strategies, case-based reasoning, and expert background and breakdowns. It's designed to guide you step by step through the most tested area and help you feel fully prepared and confident on exam day. Many of our students who have attended these sessions went on to pass with excellent scores, and that's exactly what we want for you. So make the most of today, take notes, ask questions, and if you are ready to take the next step in your preparation, I invite you to join the full revision and study with us in a focused environment, focused and supportive environment. You can find all the course detail and registration link here in this link. newptech.com course comprehensive revision. Now let's start. Let's get started. 60 questions classified according to the topics that present in the syllabus of the APC, and we will discuss them together in more details. The first section will be about biomedical sciences. The biomedical sciences represent about 20% of the exam questions. Okay. Let us see the first question and discuss it. Which neurotransmitter is primarily responsible for transmission or transmitting signals in the parasympathetic nervous system? So the neurotransmitter here is called dopamine, acetylcholine, serotonin, or norepinephrine. The right answer will be, of course, acetylcholine. Acetylcholine is the main neurotransmitter here. It will transmit, yes, it will transmit the signals from the brain to 4 pathways. The first pathway, adrenal medulla, which secrete epinephrine and norepinephrine. The second pathway to the presympathetic, preganglionic sympathetic nerve, to the ganglia. And this ganglia, the postganglionic nerve, is sympathetic. So the end result is releasing norepinephrine. The third pathway through the parasympathetic nerve, the pre-parasympathetic nerve to ganglia, then parasympathetic, postganglionic. It will complete the journey as acetylcholine to reach the organ. And the fourth pathway through somatic nervous system and somatic nerves to skeletal muscles. Okay, those are the 4 pathways of the acetylcholine from the brain. So the main neurotransmitter in the brain is acetylcholine. The second question, what is the primary function of loop of Hell in the nephron? This is the nephron formed of the capsule, and here the glomeruli for filtration, then proximal convolute tubule, the loop of Hell, either descending or ascending, then distal convolute tubule, and collecting duct. This is the composition of the nephron. Here, what is the role and the primary function of the loop of Hell? This part. Doing what? Filtration? Of course not. Reabsorption of water and solids? Hormone secretion? Red blood cell production. So the right answer here is reabsorption of water and solids. The next question. What is the primary function of surfactant in lungs? In our lungs, there is a normal surfactant present. Why it is present? To do what? Increasing alveolar surface tension, transport oxygen across the alveolar membrane, stimulate mucus production, or reduce alveolar surface tension and prevent collapse. Which is the right answer here? Reduction of the alveolar surface tension in order to prevent the collapse, the alveolar collapse. So this is the right answer, and this is the action of the surfactants in the lung. The next question. A patient in hyperventilating. The patient is hyperventilating due to anxiety. Okay. How does this affect blood pH? Previously, we studied the effect of the ventilation and the metabolism and kidney metabolism and excretion on the pH of the blood. Firstly, what is the normal pH of the blood? Normal pH of the blood in between 7.35 to 7.45. This is the normal pH. If it is less than that, we have acidosis. And if it is more than that, we have alkalosis. The acidosis and alkalosis classified according to the main reason. The source of the main reason. If the source of the main reason from the kidney or from the blood, it is metabolic. So we have metabolic acidosis and metabolic alkalosis. And if the main reason regarding or due to the lung or ventilation, it is respiratory. So we have respiratory acidosis and respiratory alkalosis. Okay, this is the first point that you should understand. What is the main reason, or regarding to which organ, regarding to the kidney or the blood, or regarding to the lung? Here, the patient having what? Having a hyperventilation due to an anxiety. So, what is the main reason here? Is it respiratory or metabolic? Of course, it is respiratory. The problem started from the lung. There is a hyperventilation. What occurs in hyperventilation? Is it high carbon dioxide exhalation or low carbon dioxide exhalation? In hyperventilation, there is high exhalation. The carbon dioxide will go out of the body fastly. So we have a low carbon dioxide concentration in the blood. Low carbon dioxide concentration means what? Means alkalosis, because carbon dioxide is acidic compound. This means that we have respiratory alkalosis. This case is called respiratory alkalosis. Yes. Let us see the choices. There is a decrease in carbon dioxide causing respiratory alkalosis. Yes, of course, this is what we explained. Therefore, the answer or the right answer here is A. The next question. Which genetic disorder is caused by mutation in the CFTR gene? What is the CFTR gene? It is cystic fibrosis transmembrane conductance regulator. The abbreviation of CFTR means cystic fibrosis transmembrane conductance regulator. It is a critical piece of human DNA located on the chromosome number 7. Okay? The mutation in this chromosome leads to secretion of viscous secretions in the lung, in the pancreas, okay, mostly in the lung, leads to what we call cystic fibrosis disease or cystic fibrosis disorder. So the right answer here is number C. If you asked about which chromosome, it is chromosome number 7, leads to viscous secretions in the lung and pancreas. What is the treatment? We have a several group of drugs used in the treatment and management of cystic fibrosis. One of them is called Dornase alpha. This Dornase alpha decreases the viscosity of the mucus due to destruction of the DNA that contains this chromosome. The next question. Which hormone is deficient in Addison's disease? Addison's disease is a disease due to deficiency of insulin, cortisol, thyroxine, or growth hormone. Of course, it is cortisol. The deficiency of cortisol leads to Addison's disease. What is the opposite condition? The opposite to Addison disease called Cushing syndrome. By the way, in some of the exam questions asking about the symptoms of Cushing syndrome. Cushing syndrome means increase in cortisol level. So without thinking about anything, without needs to memorize, increasing cortisol means the same side effects of corticosteroids. If you remember the side effects of corticosteroids, you can remember easily or expect easily the symptoms of Cushing syndrome, like hypertension, increasing blood pressure, hyperglycemia, increase glucose level. Okay. What about potassium? Hypokalemia. What about fluids in the body? Increasing the fluids in the body leads to edema. And all side effects of corticosteroids, you can apply it here. You can expect that this is the symptoms of Cushing syndrome. Let's see the next question. Which bacterium is the most common cause of pneumonia in immunocompromised patients? This is a common question also. Not only this one, but also sometimes asking about atypical pneumonia. And this question we'll discuss it in the one of the revision lectures when we discuss the last recourse. Okay, so asking about either CAP or community acquired pneumonia, or hospital acquired pneumonia, or atypical pneumonia. This question about CAP. So which of those is the most common cause? Staphylococcus aureus? Of course not. Mycobacterium tuberculosis? This will be the causative organism for TB. Pseudomonas aeruginosa? This one leads to, or the most common infection for nosocomial infections or hospital-acquired infections. Streptococcus pneumoniae, which is the most common cause. Streptococcus pneumoniae, like Haemophilus influenza, both will lead to pneumonia, yeah. Or Moxarella catarrhalis as well, also included in this condition. But the most common is Streptococcus pneumoniae. Which immunoglobulin is primarily involved in allergic reaction? If we have an allergic reaction, the immunoglobulin that mostly present in our body is IgA, IgG, IgE, and IgM. Yes, of course, it is IgE. Here I have some notes about this part. Those notes will help you to answer any question like this. Firstly, the immunoglobulin present in external body fluid. Body fluid. Here, immunoglobulin A. Immunoglobulin responsible for allergic reactions is E. Immunoglobulin present in internal or sometimes all body fluids. It is G. Okay. Immunoglobulin that responsible for neonatal immunity It is G. Immunoglobulin present in milk secretion. It is G. Okay. The most common immunoglobulin, it is G. Okay. Immunoglobulin that's responsible for adaptive immunity. It is G. Okay. Which immunoglobulin is most abundant, or the first immunoglobulin secreted when there is an infection? Which is the first immunoglobulin secreted? It is M. Okay. Immunoglobulin responsible for innate or fast immunity. It is M. Okay. If you know those notes, this type of question will be very easy for you. You will choose the right answer directly without any problem. Let's see the next one. A patient with chronic kidney disease present with hyperkalemia. What is the most appropriate immediate management? For hyperkalemia, the immediate management, firstly, what will we do? IV fluid only, or calcium gluconate, insulin with glucose, and sodium polystyrene sulfonate, or loop diuretics only, or ACE inhibitors? The right answer here is B. Each of those having its purpose. Calcium gluconate to avoid the cardiac effect of hyperkalemia. The increasing in potassium level will affect the heart. So we need to protect the heart first by giving potassium gluconate. Calcium gluconate. This calcium is not to decrease potassium level. It is for protection of the heart from the hyperkalemia. Insulin. This is the first line in decreasing potassium level. Increasing potassium needs insulin because insulin is opposite to potassium. Once insulin present in the blood, potassium will escape into the cells. They will not present at the same location in the same time. Once insulin present, potassium will escape. So insulin is the first line. Why we give it with glucose or dextrose? To avoid the hypoglycemia. What is the role of sodium polystyrene sulfonate? It is the substance that replaces sodium with potassium and prevent potassium absorption from the GIT. So this is the right answer for this question. What is the primary function of hemoglobin in red blood cells? Hemoglobin doing what? For enzyme production or oxygen transport, hemoglobin will carry oxygen. Okay. And the form of iron in hemoglobin is ferrous, not ferric. The reduced form. Why? Because the reduced form can carry oxygen, oxidated, and carry oxygen, then convert into ferric. If it is present as a ferric, it will not carry oxygen. It has no ability to carry oxygen. So here the function or the primary function of hemoglobin is carrying oxygen or oxygen transport. A patient present with severe dehydration. The dehydration topic is important in the exam. Which IV fluid should be administered initially? Initially, we need what? We need dextrose. Does dextrose doing anything? Of course not. Why? Because dextrose will distributed in the tissue very easily, leads to nothing. It will not increase the blood volume. Here we have a dehydration. We need to increase the blood volume. Half normal saline, it is hypotonic solution, which should not be administered. It will lead to hemolysis. Normal saline is the right answer. Normal saline is the right answer here. The last question in this topic in biomedical sciences. How does insulin act? Insulin doing what? Increase glycogenolysis, increase lipolysis, increase proteolysis, increase gluconeogenesis. To understand those expressions, firstly, you should know that insulin is anabolic enzyme. What is the meaning of anabolic? Building up of the substances, building up of carbohydrates, lipids, and proteins from the main constituent, which is glucose, fatty acids, or the amino acids. So it will increase building up and inhibit breaking down. So any lysis is not an action. Lipolysis, you're having lysis, it's not an action. Proteolysis, having lysis, is not an action. Okay. Glycogenolysis, also having lysis, so it is not an action. Glycogenolysis means breakdown of glycogen to glucose. So here we increase glucose. It's not an action. Lipolysis means breakdown of lipids or fats to fatty acids. So it's not an action. Proteolysis means breakdown of proteins. Also, it's not an action. Why gluconeogenesis is the right answer. Here, glyco, not glucose. Glyconeogenesis or glycogenesis. Building up of glycogen. This is the action of insulin. It's not gluconeogenesis here. Please correct it. It is glycogenesis. Let's go to the second partition of this lecture, the medicinal chemistry and biopharmaceutics, which represent about 10% of the exam questions. The first question in this part. Which property of drug primarily influences its ability to cross the blood-brain barrier? For any drug to pass the blood-brain barrier, it needs to be more lipophilic. Lipophilicity. So lipophilicity is the right answer. How does the pH of solution affect the ionization of weakly acidic drug? For weakly acidic drug, means the Ka or pKa is high or low? Yes, we have a question in the chat asking about what is the purpose of Ringer's lactate. Ringer's lactate is a solution or infusion that contains some minerals like calcium and other elements. So it's not for hydration. It's not for mainly not for hydration, but also for giving some elements to the body. Okay. Let's go back to this question. How does the pH of the solution affect the ionization of weakly acidic drug? Weakly acidic drug means high or low pKa. It is high pKa, weakly acidic. The pH doing what? If the pH is lower than pKa, what will occur? Here we have more absorption due to less ionization. If the pH equal pKa, what will occur? Equal ionization and non-ionization, so 50% absorption. If the pH is higher than the pKa, means that this acidic drug present in alkaline media, so more ionization and less absorption. Let us see the choices. Decrease ionization in acidic environment. Yes, less ionization and more absorption. This is the right statement. So the right answer here is A. How does particle size affect the dissolution rate of drug? Of course, as the particle size decrease, the dissolution rate will increase. The smaller particles dissolves faster. Smaller particles dissolves faster. Which degradation process is most commonly affected by exposure to light? When any drug exposed to light, this will doing what? Hydrolysis, isomerization, oxidation, or polymerization? Yes, you are right. It's oxidation. It is oxidation. The next question in this part. Which of the following is the least appropriate excipient to be used as a binder in tablet formulation? Let us see the excipients here, or the choices here. Starch, povidone iodine, cross carmylose sodium, or hydroxypropyl methyl cellulose. All of them are binders except one. Except, yes, cross carmylose sodium. It is not a binder. Which of the following is most appropriate flow behavior for pharmaceutical suspension? For suspensions, which type of flow we need? Is it Newtonian fluids, dilatant, pseudoplastic, or plastic fluid? Is a part of rheology that we studied previously. Here, Newtonian fluids means the fluid does not affected, or the viscosity does not affected by the shear or the pressure, just the rate of the solution, like water. Water follow the Newtonian fluid. And if the viscosity of the solution or suspension or whatever affected by the shear or pressure, so this we have, in this case, we have non-Newtonian, like dilated flow, pseudoplastic flow, thixotropic flow. Okay. Here, for suspension, which type of flow we need? We need the pseudoplastic flow. The pseudoplastic flow. Now let's go to another part, the pharmacokinetics and pharmacodynamics, which is an important topic. Very important. It represents 10% of the exam questions. Okay. Phase 1 metabolism mainly involves which reaction involved in phase 1? We have three reactions in phase 1: oxidation, reduction, and hydrolysis. Okay, oxidation, reduction, and hydrolysis. Which is the most common? It is oxidation. It is oxidation. This is the most common reaction. What about the phase 2? Phase 2 is the conjugation reaction. And this conjugation reaction, we have 6 types according to the conjugate, either glucuronidation, sulfation, glutathione conjugation, and acetylation and acylation and methylation. Okay. Let's see the next one. What is the role of cytochrome P450 enzymes in drug metabolism? What is the other name of cytochrome P450? Is liver microsomal enzymes. This is an abbreviation that you should know also. Liver microsomal enzymes. Okay. What is the role of cytochrome P450 in the metabolism? Promote renal excretion, transport drug across membranes, catalyze oxidation reactions, which is the right answer here. This is the right answer here. Let's see the next question. A drug has a half-life of 6 hours. The half here is 6 hours. Okay. How long it will take for 75% of drug to be eliminated? How can we solve this question? How can we solve a question like this? Is it 6 hours, 12 hours, 18 hours, or 24 hours? Here, the drug to be eliminated after several T-halves. The first T-half, the 100% becomes 50%. Then the second T-half, this 50% becomes 25%. So the drug in these two T-halves will lose 75% of its content, or elimination of 75% of the drug. So we have two T-halves. 6 hours is one T-half. 6 plus 6 equal 12 hours. So the answer here will be 12 hours. Okay. The next one. Which factor can increase drug absorption in gastrointestinal tract? To increase the absorption, which factor is the right here? Increase gastric motility, presence of food, lipophilicity of the drug, or increase renal clearance. Of course, it is the lipophilicity of the drug will increase the absorption of the drug from gastrointestinal tract. The more lipophilic drug, more absorbed. Okay, this does not mean that the non-lipophilic drug will not absorb it. Of course not. Non-lipophilic drugs or hydrophilic drugs has its own pores to absorb it from the GIT. Let's see the next question. If a patient's drug plasma concentration is subtherapeutic, what does it mean? What adjustment should be made? Subtherapeutic means is less than the therapeutic level. So it will not be effective and will not give that right effect. So we need to increase the dose. We need to increase the dose of the drug. The last question in this part. Which factor affect potency of a drug? The potency means what? Or what is the potency reflect? It's reflect to the effect with lower dose. When the drug will be effective in a lower dose means that this drug is potent. The rate of renal clearance or volume of distribution or half-life or receptor binding affinity. What do you think about this question? What is the right answer here? Yes, D. Receptor affinity. If the receptor affinity increase means that the drug will be more effective with a little amount. Okay, because the receptor affinity is high. More efficacy with a little amount. This is what does the potency means. If we compare two drugs having the same efficacy, it should be having the same efficacy. One of them with 10 milligrams dose and the other is 50 milligrams dose. This means that the drug A, which has 10 milligram dose, is more potent than drug B, which has 50 milligram dose. Okay, if both doses giving the same effect. This was the last one in this part. Now, let's go to another section, the pharmacology and toxicology, which represent about 15% of the exam. Which antidote is used for opioid overdose? Antidotes are very important. You should know the most common antidotes for most toxins. Here, opioids, naloxone, flumazenil, atropine, protamine sulfate. Let's do it together. For opioids, it is naloxone. Naloxone is opioid antagonist, or it is an antagonist to your receptor. So it will treat the toxicity. What about flumazenil? This flumazenil is an antidote of what? Flumazenil is antidote for benzodiazepines. Yes. What about atropine? Atropine for which antidote? Which toxin? Organophosphates. Perfect. What about protamine sulfate? It is for heparin. What is the antidote of warfarin? Vitamin K. Paracetamol. N-acetylcysteine. What about INH or isoniazide? Pyridoxine or vitamin B6. Okay. What about methotrexate? Folinic acid, or in another name, leucovorin. Okay. Those are most of the common antidotes that you should remember before the exam. The next question. What happens when a competitive antagonist is introduced to a system with an agonist? Here we have a receptor. We have the agonist for this receptor. And we have a competitive antagonist. What will occur? Agonist effect increase or agonist effect decrease. No effect of the agonist or agonist is irreversibly bounded. The competitive antagonists here compete with agonists and win this competition according to the concentration of both. So the agonist effect will decrease till its concentration will be higher than the antagonist concentration. What is the receptor desensitization? The receptor desensitization means decrease in receptor response after prolonged exposure to the agonist, or a rapid increase in receptor activation, or a condition where only antagonists bind to receptor, or a state in which receptor becomes hypersensitive. This is decrease in receptor response. Okay, decrease in the receptor response. The next one. A patient receiving warfarin is prescribed rifampin. Here we can expect an interaction. Warfarin and rifampin. Rifampin is enzyme inducer. Inducer doing what? As we learned previously, with D, will leads to decrease the level of concomitant drug. So there is a decrease in warfarin. Okay, decrease in warfarin level, decrease its efficacy, more coagulopathy. All of them are right statements. So increase toxicity, of course not. Increase anticoagulant effect or decrease anticoagulant effect. This is the right answer for this question. By the way, warfarin, the most common cytochrome that metabolize warfarin is called cytochrome 2C9. Remember this very well. 2C9. The next question. How does genetic polymorphism influence drug response? The genetic polymorphism means, the word polymorphism means what? Polymorphism means different in crystal shape. So the shape of the enzyme will be changed. This will affect the efficacy. Let us see the choices and then we choose the right answer. It causes uniform metabolism? Of course not. It alters drug metabolism and efficacy? Yes, of course. Because here the shape is changed so that the reaction between drug and cytochrome will be changed. Okay, the efficacy will be changed. Okay, and metabolism will be changed. There is an alter in drug metabolism and efficacy between individuals. The effect of the drug for one person is different than that of another person. And this is why some drugs doing a side effect for some persons and will not do for other persons. And also the efficacy of the same drug or the same characters of the two persons will be different because of the polymorphism or genetic differences between both persons. What is the main risk of taking fluoroquinolones with antacids? Antacids here, the interaction with fluoroquinolone is formation of chelates or complexes which will not absorb it. So antacids will decrease the absorption of fluoroquinolones like ciprofloxacin. We need to make a separation between doses in order to increase the absorption of fluoroquinolones. Should never give them together at the same time. So the right answer here is reduction in absorption due to chelation or chelate formation. A patient presents with pinpoint pupils. This means that meiosis or mydriasis. It is meiosis. Yes. Respiratory depression. So we can expect some of this question, some characters of these questions. Pinpoint pupil, meiosis, respiratory depression, and unresponsiveness. This is an opioid toxicity. What is the most likely cause? So we can expect here the answer. Opioid overdose, cocaine intoxication, organophosphate poisoning, or alcohol withdrawal. It is opioid overdose. This is the right answer for this question. Which of the following is a vasodilatory autocoid? Which substance leads to vasodilation? Endothelin, angiotensin 2, which is a potent vasoconstrictor. Norepinephrine, also it is a vasoconstrictor. Histamine. Histamine leads to vasodilation and leads to edema or peripheral edema. Okay, so histamine is the right answer here. Okay. Another question about pharmacology and toxicology. What type of receptor does acetylcholine primarily act on in parasympathetic nerve? Of course, it is muscarinic receptor. The alpha and beta, they are dopamine, adrenergic receptors that norepinephrine and epinephrine acts on. Okay? While dopamine is not in parasympathetic or sympathetic nervous system. Now, I think we have the most common and the most important part in the exam, which is the therapeutics and patient care. This part represents about 45% of the exam. So you should focus on those topics more than others. Let us see the first question. This part includes calculation. So we will discuss some of the calculation problems today. Let us see the first question. How much gram needed for 10% to be added to 1,800 grams of 3% to prepare 5%? What is this question, or to which part this question related to? It is mixing of 10% and 3% to get 5%. So we need to solve the question like this. Here we have 10% as a drug A. We have 3% as a drug B. Mix it together to give 5% as a drug C. The first step in alligation method, is to make a subtraction. 10 minus 5, it is 5. 5 minus 3, it is 2. So we have 2 parts of A mixed with 5 parts of B to give this concentration. We have the amount of, or the weight of, this 1,800 is for A or B? It is for B, for the 3%. So 1,800 should be put it here. Now we can solve the question very easily. By crisscross, 1,800 multiplied by 2 over 5. It will be 720 grams. 720 grams. The next question. If you dissolve 2 grams of sodium chloride in 20 milliliters of water to make saturated solution, what is the solution strength? This is a very easy question. Most of the calculation problems are very easy like this. So we need to calculate the strength after this preparation. Here, but here we have a trick. What is the trick? The trick is the concentration needed by weight per weight. Weight per weight, not weight per volume. Here we have 2 solutions or 2 liquids. So the concentration should be by weight per volume. How can we convert this weight per volume to weight per weight? We need the density or the specific gravity. So the density of the water is 1. 1 milliliter equal 1 gram. So 20 milliliter of water equal 20 grams. Okay? Thinking about this trick, however, in this calculation problem, the water having density of 1, so the result will be the same. But if we have another solution or another liquid, it may contain another or may have another density. So we should take care. Now we have 2 grams of sodium chloride present in 20 grams of water. Water as a solvent. So the total solution is 22 grams. Okay, the total solution is 22 grams. Therefore, the 2 grams of sodium chloride present in 22 grams of solution. Now we can calculate the concentration or the percentage easily. How many grams present in 100 grams? It is 9.09%. Okay, is it clear? It's a very important question because it is repeated in some of the previous exams. However, it is a very easy, but having a very important trick. If you have any question about this calculation, please ask about it before we go to the next question. Okay. Let's see the next question. How many millimoles of lithium present in 300 milligrams tablet of lithium carbonate? This question is repeated by the same digits or the same figures several times in the previous exams. So please pay attention with me in this question also. 4 millimoles, 8.3, 16 millimoles, or 2 millimoles. Let us see the answer and how can we solve this one. Okay. Firstly, to solve this question, you should know the meaning of the molecular weight of the lithium carbonate and lithium. Lithium carbonate as a molecule formed of what? Formed of 2 lithium ions and 1 carbonate ion. 2 lithium ions and 1 carbonate ions. So each 1 millimole of lithium carbonate contain 2 lithium and 1 carbonate. Right? This reflects the weight of the molecule. If the weight of the molecule, the total molecule is 73.9. This is the weight of the molecule. This weight divided into 2 parts. The weight of lithium inside the molecule and the weight of bicarbonate or carbonate. We have 2 lithium ions, means each 1 lithium is 6.8 or 6.9. 2 lithiums means 13.8. So the weight of the lithium inside the molecule is 13.8, means each 73.9 lithium carbonate contain 13.8 lithium. This is the key for solution of this question. We have 300 milligrams of the lithium bicarbonate or lithium carbonate, I'm sorry. This means the lithium itself, its weight inside this content or inside this weight is 56 milligrams of lithium. Now we have the weight of lithium. Can we calculate the number of moles or millimoles of lithium? We have the rule saying that millimoles equal weight over molecular weight. We have the weight, which is 56. We have the molecular weight, which is 6.9. Now we can calculate the number of millimoles, which is 8.1 or approximately 8.3, which is the right answer. Okay? Don't leave this question without any asking. If you understand it, okay. If you don't understand any step, please ask about it. It's a very important one. Okay. Now let's see the next one. Another one repeated. The composition of 2 grams. The composition of 2 grams suppository is 1.8% balsam pyrrole. How many milligrams of balsam pyrrole is required to prepare 12 suppositories? We need to prepare 12 suppositories. Each suppository contains 2 grams. Okay, its weight is 2 grams. And the percentage of balsam pyrrole in each is 1.8%. So we can solve it by the following. Firstly, you should know what is the meaning of 1.8%. 1.8% means 1.8 grams present in 100 grams. We have 12 suppositories, each one of 2 grams. So we have the total weight of 24 grams suppositories. Containing how many grams of balsam pyrrole? By crisscross, it would be 0.432 grams. Okay, but take care here. The answer should be by milligrams. So we should convert these 2 milligrams by dividing or by multiplying by 1000 to get 432 grams. One gram penicillin every 6 hours and given for 3 days. If 150 milligrams equivalent to 250,000 units, then how many units will be in the total dose? Also, this one is repeated. Okay, how can we solve this one? It's a very easy one. The total dose, firstly, should be calculated. Here we have 1 gram of penicillin every 6 hours, means 4 times daily for 3 days. So the total grams is 12 grams. Okay. He said that if 150 milligrams equivalent to this number of units. So the 12 grams or 12,000 milligrams equivalent to how many units? Would be to 20 million units. Those some of the calculation problems that present in some of the previous exams. So please focus on them and you should understand them very well, how to solve them very well. Sometimes repeated by the same figures and sometimes change the figures, so you should understand the method for calculation. Now let us see some other questions. Which neurotransmitter is deficient in Parkinson's disease? We are talking about dopamine. Dopamine is deficient in Parkinson's, and the treatment is dopamine precursor or dopamine itself, or not dopamine agonists. So we have levodopa is the main drug of choice in this condition. This levodopa should be combined with some other drugs like carbidopa, rasegalene or seligalene, and entacapone. What is the purpose of each of them? Carbidopa is a dopa decarboxylase inhibitor, so that prevent the conversion of levodopa into dopamine in the peripheral part, letting levodopa pass the blood-brain barrier, then convert to dopamine in the brain. Seligalene is now B inhibitor, so that inhibit the metabolism of levodopa to other compound other than dopamine. Entacapone is catechol O methyl transferase enzyme inhibitor. Also prevent the conversion of levodopa to another compound, making levodopa the only pathway is conversion to dopamine in the brain and leading to raising the dopamine level and controlling this condition. Okay. The treatment of Parkinson's also may be with dopamine agonists like the ergot alkaloids bromocriptine, or non-ergot alkaloids like apomorphine or other drugs. Also, we can use amantadine in the treatment. Which drug class is first line for hypertension? For hypertension, the first class is ACE or ARBs. So the question may come in by those choices or change the choices into for beta blockers, for example, atenolol. Here we have lisinopril or whatever, any ACE inhibitor. Statin, here we have simvastatin and ibuprofen. So the choices may be the name of drugs, and you should know the groups that each drug related to. A patient with congestive heart failure prescribed digoxin. Which form or digoxin described to which condition? Decompensated congestive heart failure. Okay, it is positive inotrope. Okay, digoxin, one of the non-therapeutic index drugs, and you should know the therapeutic level of it. So we need to monitor this drug. We need to monitor what? Which element or which mineral should be monitored, or which electrolyte should be monitored very closely? It is serum potassium. Why? Potassium level is opposite to digoxin toxicity. Means if potassium increase, digoxin toxicity will decrease. And if potassium decrease, digoxin toxicity will increase. So that we should not, or we should never give any drug deplete potassium with digoxin at the same time, like loop diuretics, azide diuretics, calcium channel blockers like verapamil or digoxin, not due to potassium, but due to additive effect on the heart, and also the opposite effect on the chronotropic effect. So verapamil and diltiazem should not given with digoxin. Loop diuretics and thiazide diuretics should not be given with digoxin, and we should monitor potassium level very closely. What is the first line drug for type 2 diabetes? Type 2 equal metformin. But you should add an important statement. Unless contraindicated. This should be added to this statement. Means what? Metformin is the first line in type 2. But if there is a contraindication to metformin, like renal impairment or kidney failure, liver impairment, congestive heart failure, or using of contrasts, iodinated contrasts especially, those will lead to lactic acidosis. And this will be contraindication for administration of metformin. Which hormone is dominant during luteal phase of menstrual cycle? Here we are talking about progesterone. Progesterone. Which drug is commonly used for acute gout attack? In acute gout attack, we don't need urate lowering agents. Okay, we don't need urate lowering agents, but we need anti-inflammatory drug. We have two drugs here. NSAIDs, especially endomethacin, and colchicine. So regarding to those choices, colchicine is the right answer. What is the dose of colchicine, which is important also in the exam? You may ask about the dose of colchicine. Not 500 microgram. 500 microgram is a right maintenance dose, but you should remember the full dose. What is the full dose? Is 1 to 1.2 milligram as a loading dose. Loading dose once. Okay, then followed by 0.5 to 0.6 milligram, or as you mentioned, 500 to 600 microgram. 3 times daily till resolution of the case. Okay, what about allopurinol? Can we use allopurinol in acute gout attack? You should not start with it. Why? Here we are talking about an inflammatory condition. Allopurinol doing what? Allopurinol will decrease the uric acid level by xanthine oxidase enzyme inhibition. This may lead to migration of uric acid or monosodium urate crystals. This migration may lead to more precipitation of these crystals in the joints and more inflammation. So the starting with allopurinol is not recommended. Okay, but if you have acute gout attack, you should start with NSAIDs or colchicine. Okay, and if the patient already using allopurinol, he should continue with allopurinol. There is no problem, but should not start with it from the first. Is it clear? Which of the following is a common side effect of methotrexate? It is a common question and repeated several times as well. Hyperglycemia, bradycardia, myelosuppression, and peripheral neuropathy. Here, regarding to the choices, the myelosuppression is the right answer. What else? Myelosuppression plus hepatotoxicity. This is another serious side effect of methotrexate. A patient with chronic constipation is prescribed polyethylene glycol. What is its primary action? What is the primary action of polyethylene glycol here? Okay, we have chronic constipation. Polyethylene glycol is a laxative, but acting by which mechanism? It will soften the stool by increasing water content. Okay, it will not stimulate peristaltic movement like senna or bisacodyl. They are stimulant laxative. Increasing the stool bulk, we have the psyllium, bulk forming laxatives. Okay, reduction of intestinal secretions, we have another drugs. The polyethylene glycol is increasing the water content, is an osmotic laxative. Which hormone is deficient in Addison disease? I think this repeated question. We mentioned that it is cortisol. A patient with myasthenia gravis. What is the myasthenia gravis? It is muscle weakness due to decrease in acetylcholine in the neuromuscular junction. So there is no contraction of the muscles. The treatment by cholinesterase enzyme, the reversible one, the stigmine family, like pyridostigmine and neostigmine, which cannot pass the blood-brain barrier and act peripherally. What is the mechanism of action? I mentioned it. They will inhibit acetylcholine esterase, and therefore it will increase acetylcholine. Acetylcholine with choline esterase, it will be metabolized into acetyl part plus choline part, which are ineffective. We will inhibit this destruction or this metabolism by pyridostigmine, so that acetylcholine will increase, its level will increase in the peripheral part, leading to treating this muscle weakness. Which of the following is the most appropriate therapy adjustment for diabetic patient with declining renal function? We need what? Increase metformin dose, or discontinue metformin, or replace metformin with sulfonylurea, or increase insulin dose. Here it is one of the contraindication of metformin due to lactic acidosis. Increasing of metformin dose will increase lactic acidosis. So it is not a right answer. Discontinue metformin is important. Is the right answer. Replacing it with sulfonylurea. Here, mostly the patient having type 2 diabetes, sulfonylurea may be or may not effective, okay, according to the case, but this is not the most appropriate. The most appropriate, firstly, stop metformin, then start to find another drug according to the patient's profile. Okay, so it may be right answer here, replacement of metformin with sulfonylurea, but maybe the right or the most right is stopping metformin. Some questions will be tricky like this, like the previous. Okay. A patient on warfarin therapy has INR of 5.2. What is the normal range of INR if the patient receiving warfarin? It is in between 2 to 3, or some cases 2.5 to 3.5. So we have here high level of INR, but not bleeding. There is no bleeding, but the risk of bleeding is high. What is the most appropriate intervention? There is a risk of bleeding, but no bleeding and no very high INR. We need vitamin K administration. This administration mostly will be oral administration. Discontinue warfarin for 2 days. The discontinuation of warfarin is not the appropriate intervention. We should stop warfarin for some days, not 2 days, not 3 days, and this is according or determined according to INR level. Okay, so we should measure INR level before recontinuation of warfarin in a lower dose. Okay, reduce warfarin dose and monitor INR, not reducing. We need to stop warfarin till INR level reach in between this normal level, then continue the warfarin at lower dose, but we should stop firstly. Administration of fresh frozen plasma, we don't need. There is no bleeding, no severe bleeding, so there is no need for this fresh frozen plasma. The most appropriate answer here is administration of vitamin K, and if this statement contain also stopping of warfarin, it will be more correct. So let us say the steps. Stop warfarin administration. Okay. Add vitamin K. Oral, mostly will be oral because here we have a little increase with no bleeding. So a little amount of vitamin K will be enough. Okay. Check or monitor INR till its level reach the normal level. Continue warfarin at lower dose. Those are the steps of solvation of this toxicity. Okay. In between stopping and recontinuation of warfarin, you should make a bridge. A bridge of what? A bridge of heparin. Because the patient should be protected. If you stop warfarin, the patient here is unprotected. Okay. And also he take or administer vitamin K, which make the unprotection is more higher. So you should protect the patient with heparin till the continuation of the warfarin. Which antipsychotic has the highest risk of metabolic side effect? Highest risk of metabolic side effects occur with haloperidol, aripiprazole, ziprasidone, or olanzapine. Is olanzapine, which leads to hyperlipidemia, one of the atypical antipsychotic agents. A patient with penicillin allergy needs an alternative 4-gram positive bacterial infection. What is the best option? Amoxicillin? Of course not. Cefalexine? Also not. There is a cross sensitivity here. The first generation and second generation response should not be given here. Azithromycin? Yes, it is the right answer here. Yes, azithromycin is the right answer here. Vancomycin is not the right choice. What is the first line treatment for anaphylaxis? If the patient having anaphylaxis, the first line is Which of those? All of them should be given. Antihistaminic, corticosteroids, epinephrine, and maybe oxygen therapy in some cases. So which is the first line of them? It is epinephrine. EpiPen or an auto-injector of EpiPen is the first injection that the patient should receive. A patient present with acetaminophen overdose 6 hours after ingestion, I'm sorry. What is the most appropriate treatment? Here we are talking about an acetylcysteine as antidote. Which of the following drug requires therapeutic drug monitoring? TDM is an important abbreviation repeated several times in some of the previous exams. Here we have acetaminophen, lithium, ibuprofen, lisinopril. Which of those requires therapeutic monitoring? It is lithium because of narrow therapeutic level or narrow therapeutic margin. Another question by the same idea repeated in the exam. Which is not need or not require therapeutic dose monitoring? And here, this is a tricky question because all the choices needs therapeutic drug monitoring. Warfarin, cyclophosphamide, gentamicin, theophylline, or lithium. It's not cyclosporin. Cyclosporin. The answer here is warfarin. Yes. Why warfarin? However, we need to monitor it. Here, we will not check the warfarin level itself, but we will check INR. While others, we check the level of the drug itself, the concentration of the drug itself. Okay? So you should take care about a question like this. Warfarin is the right answer in a question like this. Let us see this one. How does the half-life of a drug influence dosing frequency? When there is a short half-life, the dose frequency increase or decrease? Well, increase. A long half-life, the dose frequency will decrease. Okay, so the first and second choice are wrong statements. Shorter half-life require more frequent, which is the right answer. What is the most appropriate counseling advice for a patient taking bisphosphonate? It is an important question and repeated many times previously. Take with food? Of course not. Take with a full glass of water and remain upright for 30 minutes, which is the right answer and the right advice for this patient. A patient with chronic kidney disease requires an opioid for pain management. Okay, which of the following is the least appropriate choice? Fentanyl, morphine, oxycodone, or hydromorphone? The least appropriate for opioids for patients having chronic kidney disease is morphine. Which of the following medications is contraindicated in pregnancy? You should know drugs that contraindicated in pregnancy very well also. Metronidazole, insulin, lisinopril, ACE, and ARBs are category X in pregnancy. Also warfarin. Okay, so you should know the category X in pregnancy very well. Which of the following is a common adverse effect of ramipril? One of the ACE. So ACE equal cough. Why dry cough? Because ACE inhibitor will inhibit the conversion of bradykinin into its inactive metabolite. Bradykinin is the reason for the dry cough. So ACE inhibitors will lead to dry cough. However, the ARBs, or while ARBs does not do that because they will not inhibit this deactivation. This was the last question today, and last question in this type of revision. I hope it was a very useful revision for all of you, and thank you very much for your attendance. Before we finish, I open the discussion. This is an opportunity for all of you to ask what you need. By the way, this revision was recorded, and I will share the recorded video for all of you, so you can listen to the lecture from the first again. If you don't attend the lecture from the first, you can listen to it again and get the first questions. There is no problem. No, any question regarding to the exam or the revision or about selegiline. Selegiline is MAO-B inhibitor. What is the meaning of MAO-B inhibitor? Monoamine oxidase or selective monoamine oxidase B inhibitor. Selegiline acting on the brain. Selegiline can pass the blood-brain barrier, reaching the brain and doing what? Inhibit the enzyme monoamine oxidase B. This monoamine oxidase B has an effect on levodopa. Convert the levodopa into inactive metabolite. Okay. Selegiline will inhibit this MAO-B, so inhibit the conversion of levodopa into an inactive metabolite, and making levodopa going to the only pathway we need, which is dopa decarboxylase enzyme into dopamine. This is the action of selegiline. What else? You have any other question? Okay. By the way, if you need any help or you have any question, you can contact me directly with the following WhatsApp number. This is my WhatsApp number, so you can contact me directly if you need any help or any question. Also, as I mentioned, you can join the full revision for persons or students who does not or didn't join us previously. From this link, uptech.com, you can find the revision course and join it to join our coming revision, which starting on the 3rd of July. we have 3 revision sessions. 3rd of July, revision 1. 7th of July, revision 2. By the same way, but we will discuss more questions. Everyone will discuss about 120 questions, like the exam, with the same distribution of the content. And the third one, which is the most important one, because it contains last exam questions, real questions from the last exam, which we call it recalls of the last exam. So it is the latest recalls, and the opportunity of them is high in the coming one. Plus, you will find in the full revision the mock test that mimic the real exam. This is the content of the full revision if you need to join. For persons who are joined our course, our full course, this revision is included in the course, so you don't need to join again. Okay, you will find all of them with you and you can attend them easily. We have 2 questions here. Why morphine is least appropriate for chronic kidney disease? Because it is affecting the kidney and excretes through the kidney. So here it should not be given for a patient who having chronic kidney disease. IgA is present only in the external fluids like saliva and lacrimal fluids. So the breast milk contains immunoglobulin G. Okay, finally, I'd like to thank you so much for this attendance, and I'll be happy if you send me any question in the WhatsApp number as I shared. I will reply either directly or after some times. Don't worry, I will reply. This is sure. Okay. There was another questions, so let us answer them before we finish. Why allopurinol is not used in acute gout? Allopurinol is not for treatment of acute gouty attack. Allopurinol is a drug that lower uric acid level, okay, by its mechanism through the enzene oxidase enzyme inhibition. If you start with it during the acute gout attack, it will lead to migration of uric acid crystals to the joints, which leads to more inflammation. Therefore, it is not recommended for the patient who having acute gout attack. But if the patient already using it before the gout attack, he will continue with it. Okay, is it clear? Ringer lactates can be given for some electrolytes deficiency. Okay, but it is not the first one for hydration of the patient. If the patient having dehydration, the saline solution is the first line. Yes, I will share the record in the WhatsApp group, in the YouTube channel, and in Facebook groups and pages, and also in the website. So you will find the recorded lecture in the website also, www.newptech.com. Yes, of course. There is a PDF for the 3rd revision. Yes, of course. Okay. Finally, thank you so much, and see you in the coming revision which will be on the 3rd of July. Thank you and goodbye.